Tuberculosis, also known as TB, is an infectious disease caused by the bacterium Mycobacterium tuberculosis. About 1/3 population of world can be infected by this disease. Pakistan is ranked 5th country among 30 high-burden countries in world. Pakistan, with population of 221 million, have an estimated number of 573,000 (GTB 2021) cases, while in 2021 the country notified to 339,256 cases. Pakistan is ranked 5th country among 30 high-burden countries in world, with an estimated 25,000 cases MDR-TB cases among estimated TB cases. 4.2% cases are new cases and 7.3% among previous treated cases. Tuberculosis may be pulmonary or extrapulmonary. TB is spread through the air when an infected person coughs, sneezes, or talks. Symptoms can include a persistent cough that lasts for more than 3 weeks, coughing up blood, chest pain, fever, night sweats, weight loss. First-line TB treatment: isoniazid, rifampicin, ethambutol, pyrazinamide. Second-line TB treatment: silosarin, ethionamide, levofloxacin, moxifloxacin, para-amino-salicylic acid, linezolid, clofazimine, bedaquiline, dilanamide, amikacin, capreomycin. WHO recommended regimen for TB: 1. 2-HRZE, 4-HR. For newly diagnosed pulmonary and extrapulmonary TB: 1. 2-HRZE, 6-HE. 2. 2-HRZE, 10-HR. For newly diagnosed cerebral TB. Drug resistance to TB. MDR, multiple drug resistance. TB show resistance to isoniazid plus rifampicin. Extensive drug resistance, XDR, is a type of drug-resistant tuberculosis that is resistant to both first-line and second-line anti-TB drugs, including fluoroquinolones and injectable drugs such as amikacin, kanamycin, and capreomycin. Test. To diagnose drug-resistant tuberculosis, Dr. TB, various test is performed. 1. Gene expert test. The Gene Expert MTB, RIF assay is a specific type of gene expert test that can also detect resistance to rifampicin, one of the key drugs used to treat TB. Rifampicin resistance is often used as a marker for multi-drug resistant TB, MDR-TB, which is resistant to at least 2 of the most effective first-line anti-TB drugs, isoniazid and rifampicin. If the gene expert not show resistance to rifampicin, then it is not the case of Dr. TB. If they show any resistance, further confirmation we will perform LPA. 1. Line probe assays, XDR expert. To find which drug is showing resistance: isoniazid, rifampicin, pyrazinamide, dilamide. 3. Drug susceptibility testing, DST, or culture test. This is test of sputum test which should be performed every month, and the result will come after 2 months. If 2 consecutive result is positive during the treatment regimen will be changed. The choice of diagnostic test for Dr. TB may depend on factors such as the availability of laboratory facilities and expertise, the severity of the patient's condition, and the local prevalence of drug-resistant strains of TB. Treatment regimen for Dr. TB patient. The treatment of Dr. TB patient is 11 to 20 month. 1. Shorter treatment regimen. 11-month treatment. 6-month, 5-month. BDQ, LFX, CFZ, H, Z, E, ETO, LFX, CFZ, E. If STRs fail, the resistance may occur. We should move toward LTR2. 1. Long-term treatment. 1. LTR1. 18-month treatment. 6-month, 12-month. BDQ, LFX, CFZ, LS, Z, Cs, LFX, CFZ, E, Cs. 1. Long-term treatment, LTR2. 18-month treatment. 6-month, 12-month. BDQ, CFZ, AMK, DLM, LS, Z, Cs, LFX, CFZ, E, Cs. 1. Long-term treatment LTR3. 20–24 month. If the treatment is fail. 20 BDQ, DLM, LZD, ETO, PA. 1. BPAL, BPALM treatment regimen. 6-month 9-month depend upon culture. If patient is resistant to only fluoroquinolone. 1. BD, PA, LZD. If not resistant to FQ. 1. BD, PA, lazed, MFX.